Okay, wonderful. Thank you everyone for joining us. Good afternoon. Welcome to our webinar and panel discussion on tackling sickle cell disease, new strategies for building India's momentum. This is a good time to have this event, at least for two reasons that I'm aware of. It's World Sickle Cell Day. So it's important to mark it every year for all the people who are making efforts towards the elimination of this disease. And secondly, more a good time to take stock as well as find opportunities. Am I audible, Alessio?
You were breaking up for a moment.
Yeah.
I see.
You're audible.
Okay. This is, my name is Dhananjay Vaidyanathan Rohini. I'm a founder at Alstonia Impact. So Alstonia Impact is a social impact and a public health advisory and research firm. We will talk more about ourselves in a bit, but let me share the plan, how we're planning to do this for the next hour or so. First, the team from the Alstonia Impact side will share summary findings of what we found as opportunities over a 3-month study. Then we will move on to this exciting panel discussion. Some of the panelists are here already. We will introduce them at that point. We will take audience questions as well. So feel free to put your questions. Okay, I think Dr. Srivastav, you're audible now.
Yeah.
Okay, great. You can ask questions at any point in the Q&A box that is available. They will be taken up towards the end of the session. So without further ado, let me move on to the first section, which is the presentation from the Alstonia Impact team. I'll hand over to the team, starting with Japneet.
Thanks, Dhananjay, and thank you everyone for taking out time today to be a part of this webinar and panel discussion as we mark the first anniversary of the government's mission to combat this disease. Before we get started, I would request the presenters to briefly introduce themselves, and I can start us off. I'm Japneet, and I lead the research division at Alstonia Impact. Chandni, could you go next?
Sure. Thank you, Japneet. Hi, everyone. I'm Chandni. I'm an associate at Alstonia Impact. Thank you so much for joining in. Over to you, Kanishk.
Hi, everyone. I'm an associate at Alstonia Impact, and I worked extensively on this SCD project.
Thank you, Kanishk. Thanks, Chandni. Okay, so we would begin with the objectives of our landscaping study, followed by the background on NCD and SCD and SCD burden in Indian states. And then we would briefly discuss the current health system response and challenges faced by the patients and health systems, followed by the recommendations for key stakeholders to tackle SCD challenges at systemic level. Now, next slide. Thank you. So the key objective of this landscaping study has been to identify the gaps as well as associated opportunities for stakeholders, including funders and government, to engage and strengthen the health system. And to conduct this study, we relied on 3 main methods, including extensive secondary research, key informant interviews with stakeholders like government, NGOs, donors, and patient representative organizations, which are mentioned here on the right-hand side. And we got insights from experts in this field, and the idea was to validate these findings as well from the secondary research. And then based on the limited quantitative information that's available and the insights that we got from the interviews, a care cascade model was developed to estimate where the biggest challenges are in the patient's end-to-end care journey. I'll hand over to Chandni now to get us started with our findings.
Thank you, Japneet. Now we'll be looking at understanding what sickle cell disease is, its impact on patients, and the burden of the disease in India. As you all may already know, sickle cell disease is a hereditary condition that causes a red blood cell to lose its typical shape and take on more of a sickle-like form. Sickle cells also last only for 10 to 20 days, in contrast to the typical 120-day lifespan of a healthy RBC. This leads to chronic anemia, immune system challenges, and persistent damages to the patient's spleen. People with SCD are also at a higher risk of infections such as flu and pneumonia, and symptoms of SCD usually appear around 6 months of age. Talking about the impact of the disease on patients, people with SCD have lower life expectancy of around 54 years, in contrast to 76 for a healthy individual. and also have lower projected lifetime income. Talking about the burden of the disease in the country, the states of Odisha, Maharashtra, and Madhya Pradesh have the highest number of SCD cases, followed by Jharkhand. In all of these cases, the majority of the burden is in the tribal population. Next page, please. Talking about the government's response to the disease, the National Sickle Cell Anemia Elimination Mission was officially launched in July 2023 with the objective of eliminating SCD as a problem by 2047. The program is led by the Ministry of Health and Family Welfare and is being implemented by the National Health Mission with the support of Ministry of Tribal Affairs in 278 districts in 17 states of the country, including the 4 high burden states. As a part of the program, the government has taken various initiatives to increase awareness about the disease, to increase the coverage rates of the screening program across the country, to improve the access of medication, and also improve the screening of the program throughout the country through data management. Now I'll be handing it over to my colleague Kanishk, who will be talking about the various challenges in SCD management. Over to you, Kanishk.
So from our research, several major challenges emerged for both the patients and the health system across the whole care journey. So I'll speak about the most significant ones. The first being lack of awareness among community, patients, and even healthcare workers. According to a multi-centric intervention study conducted in 2021 across 6 high prevalence SCD states, there is a gross inadequacy of knowledge about SCD, especially in the tribal population. As per the study, only 32% of the close to 10,000 participants that had heard of SCD, only 19% knew that a blood test can diagnose SCD, and only 13% knew that SCD can be prevented. Moreover, affected populations, especially the tribal population, tend to hold many incorrect beliefs about SCD and are hesitant to seek support because of the stigma associated with it. Misconceptions vary state to state that include causes such as infection, poverty, or even myths such as God's curse, fate, or black magic. Moreover, there is a high reliance on traditional healers due to mistrust in public institutions, which is well documented. But in a research published in 2022, most traditional healers are unaware about the cause of SCD and give symptomatic treatment by providing herbal medicines and performing rituals. These are symptoms and to diagnose the disease.
Okay. Sorry, Kanish, you were breaking up for a moment. Now you're back. In case it happens again, I'll ask you to turn off the video. Over to you.
Sure. So patients are rarely advised about even simple strategies to manage the symptoms, such as avoiding dehydration, overexertion, or high altitudes, all of which can trigger a pain crisis. The other challenge that we came across is a lack of resources, the number of to comply with guidelines. Lack of basic health infrastructure in remote tribal and rural areas leads to improper or delayed treatment. There are challenges in conducting prenatal screenings and newborn screening at scale in most states due to limited diagnostic tools at facilities close to populations. Moreover, resistance from parents against newborns being pricked during the screening process is also a significant barrier. Additionally, high rates of home deliveries among tribal populations exacerbate the challenge of accessing newborns for screening. And even though operational guidelines specify centers of excellence for SCD, but implementation is currently lacking at this front. Can we move to the next slide, Alessio? On the execution front, program implementation, sorry.
Apologies, Kanish, but can you please turn off your video?
Sure. Is it better now?
Yes.
Okay. So on the execution front, program implementation still has some areas of improvement, including lack of integration with local communities and pharmacists. We have heard from various state stakeholders about the limited human resource capacity and occasional stockouts of key medicines and limited coverage of newborn screening, as well as limited availability of new drugs and recommended vaccines. The other major challenge is the limited relevant evidence, which includes data gaps about the burden, reasons for leakages in the care cascade, and reasons for lack of treatment adherence. All these major challenges limit the ability to steer the program effectively. Now I'll pass on to Japneet, who will talk about the quantified care cascade through which we tried to quantify these challenges and helped us prioritize the solutions.
Thank you, Kanishk. So we developed the care cascade using this detailed funnel, starting from the total SCD positive people. And of them, how many get screened or seek care? And of those, how many get diagnosed? Since of the ones screened, some still may not get diagnosed or not seek care to be diagnosed. And then of those diagnosed, how many started treatment? And here, there may be drop because of lack of access to right medication, for instance. And though of those who started treatment, how many adhered to it? Low motivation, financial challenges, social stigma, treatment not being effective could be some possible reasons for the drop in adherence to treatment. So the idea was to use this care cascade to prioritize challenges and associated solutions. And the next slide shows our findings. So given the limited quantitative data available, we had to make certain assumptions to develop this care cascade. And based on our model, we found biggest drops at diagnosis and treatment adherence stage as shown in this figure, with 44% drop between care seeking or screening and getting diagnosed, and 53% drop between treatment initiation and adherence. And lack of awareness, both in the community and among the health workers, seems to be a key factor contributing to these drops, which was also revealed during the KIIs. And we recommend a higher priority on challenges related to timely diagnosis and treatment adherence of those identified.
If I may come in, Japneet, really quickly. This is Dhananjay. So in many other disease areas, we have seen this quantified care cascade, which helps public health.
DJ, we cannot hear you.
Lost you again. Okay, over to you, Japneet. Continue and then.
Sure. Okay, maybe we'll come back to this point that Dhananjay wanted to share on care cascade. But we wanted to share our recommendations for the key stakeholders that we've identified to tackle SCD challenges in the next slide. Yeah. And here, we've shared the recommendations that seem to have high impact and feasibility. There are several other recommendations as well that we would be happy to share with you in a more detailed slide deck. First key recommendation would be improvement in awareness about the disease and trust in the public institutions among the community as well as the health workers. So running mass media campaigns for community to fight social stigma related to the disease is critical. And at the same time, training health workers and ensuring they know how to identify the disease and provide vaccines and other treatments is another important step that's much needed. Then the other recommendation is to provide adequate resources, like building and scaling centers of excellence for advanced treatment, particularly in high prevalence areas, and training low-level facilities in a phased manner. Alyssa, next slide, please. Yeah. Further improving execution in terms of implementation of the program, particularly improving coverage of newborn screening in public facilities, managing human resources effectively, preventing stockouts of key commodities, measuring program and success, as well as treatment disease management by including catch-up vaccines and new therapies is equally important. And lastly, evidence generation to discover the definition of an optimal operating model for providing care close to the communities, and understanding how beliefs and myths vary by region and tribes is important to be able to better design better social and behavior change communication efforts. So I think we've shared quite a bit of information in the last 15 minutes to digest. And now it would be great to hear from our panelists on what they think about tackling sickle cell disease. And Dhananjay, if you're able to
Yes.
speak. Okay, great.
Yes. Thank you. Thank you very much for the presentation, Japneet and team. Apologies for my connection. Am I coming through clearly now?
Yes.
Okay, great. So, I think the one thing that stood out here was the quantified care cascade, which we see in so many other diseases that we work in, for example, TB, HIV, to really understand what's going on, where are we losing people, at what level, and given finite resources, where to focus our efforts rather than trying to solve everything. Of course, there are challenges across the board. The government's put up a really interesting program to tackle this, but where should we as a community be spending most of our time and effort? That was the first attempt, which we could not find in the literature, so we ventured to create this care cascade. Thank you. Let's go back to the slide and get started with the panel. Let me take a shot at introducing some of our eminent panelists in the order that you see on the screen. Dr. Deepti Jain needs no introduction, but she is and head of department at the Government Medical College of Nagpur, Maharashtra. She has over 30 years of experience serving sickle cell patients. She was also the chairperson of the task force towards elimination of sickle cell anemia by 2047. She also wears another hat, which we'll talk about a little bit later, is that she's been involved in a number of research studies in this area, and she's been moving the science forward, so we'll come back to that. Dr. Mukul Agarwal is assistant professor at the Department of Hematology at AIIMS. He teaches, the next generation of doctors in this area, and he also sees patients from across the country who make their journey to AIIMS, both patients with complications and some of the early cases, because AIIMS also does OPD. So he has both clinical as well as academic knowledge of this field. Dr. Murthy Uppaluri is in his second innings, and now he's with the Piramal Foundation and runs the Tribal Health Collective. Prior to this, he was a globally recognized business and technology leader, working at several organizations, including Microsoft. Dr. Vinita Srivastav, she has decades of experience implementing and designing programs at the government level. She is currently with the Ministry of Health and was previously at Advisor Health in the Ministry of Tribal Affairs. So she's probably one of the few people who has seen the central government's efforts from both sides. And we hope that she will bring to bear that experience in the conversation that we will have. And lastly, Gautam Dongre is the founder of the National Alliance of Sickle Cell Organizations, which is an organization of alliance of over 25 organizations on managing sickle cell disease. The alliance raises awareness and carries out advocacy in the country. So welcome all, and looking forward to the conversation. We hope to have a free-flowing conversation here as it up. Starting very much with the patient in mind, and who better than Gautamji. You have seen many patients. You run an organization which is an alliance of sickle cell organizations. You also have a personal connection with the disease. If you could, for the audience, describe the typical journey of a patient from the time that he or she is born, perhaps even contrast how that varies depending on where that patient is born, whether that's in a city or in a poorly connected area with tribal populations. This would help us get going. Thank you.
Thank you so much, sir. The journey of the patient, I would like to start from my both son and daughter, both are affected with sickle cell disease. And my son is 18 and my daughter is 13. So I can share my own story with living with both sickle cell child. Really, it is very difficult to define in the words that how can we live with the sickle cell child, because this disease, as you all speaker already spoke, that it is very, very, very dangerous, and it's a very horrible disease when we live with this type of childs in our home. So many times my both son and daughter admitted in the hospital in same time. Many times, I think since last 15, 17 years, we couldn't enjoy the holy Diwali like festival in our home, because at the time of festival, at the time of exams, at the time of any kind of event, one of my son or daughter got crisis due to the excitement, maybe, or whatever, over exhaustion, whatever the things happening. But since last 17 years, we couldn't enjoy our social life. So not only our social life goes down, but also the economic and every aspect, it comes the family to the downstate. So I am living in a Nagpur area, and which is a very great city where the Dr. Dipti Jain ma'am is there, and we are very thankful to her that our both child are getting treatment from her. So we are right now in very safe hands because government is also doing very nice, that providing all the treatment medicine in free of cost. So in my condition right now, we are in very safe hand. But in rural area, in remote area where the maximum persons are sickle cell with sickle cell disease are living, they are not getting much awareness, much treatment, because they first go to the PSC or sub center, or uh, most often district health centers. But the awareness is really very less right now, but government is aggressively doing since last few years. And as you are aware that there is a sickle cell mission, so we are really very hopeful that our tribes people will definitely get what we are getting in Nagpur like cities. So these are my stories in short, because the time is limited.
Yeah.
And I must share the social stigma also with this disease. Thank you so much.
Yes, Gautamji, I was just going to ask you if, from the perspective of a rural patient, can you talk a little bit about the stigma associated with this particular disease and how that plays out in communities?
Yeah, there is a lot of stigma as we are working in a pan-India level. So in different states, there is a different stigma associated with sickle cell disease. I am living in Vidarbha, Maharashtra. In this region, people used to say that this disease is a specific community disease, and those type of people who used to eat dead meat in 1,000 years before. So that type of community is having this type of disease. So sickle cell disease is associated with dead meat in Vidarbha who are taking. Same in Chhattisgarh, there is a community who is having more prevalence of sickle cell disease. They are all rice uh, eater. We may say that they used to eat rice, old rice. So the myth is there that rice eater may have the sickle cell disease. And same time in Gujarat also, the chapati of rice, those who are taking, these people are affecting with the sickle cell disease. So different states, there is a different type of stigma. Just and mainly the people knows that this is the curse of goddess. So that's why the people having this type of sickle cell disease. So social stigma is a very crucial part of this disease for spreading. Because of that, people goes to the, you share that black magic superstitions because of the disease. And in my view of last 4 years, my conclusion is that the person when symptomatic, just like a body pain, severe crisis, a jaundice or anemia, they usually go to the doctor. But what happened, they are not diagnosis on that time, they are only treating of the symptomatic treatment. So what happened with this family, that they understand that we are going continuously to the hospital, but our child is not curing. After 2 months, 3 months, again it goes to the crisis. So the belief with the medicine goes down, and the belief with the God or any outside, it's raised, and then that family easily turn to the superstitions. So this is not their fact. Actually, the diagnosis of right time diagnosis and the medicine is can do the very key role to eradicate this mission. Because I also felt sometimes when my son was 2.5 years old and he was getting many crises since childhood. So me, like educated person, also went to the these type of people that why my son is not getting cured. So this is very
Thank you.
important.
Yeah.
Thank you.
Thank you, Gautamji, for portraying those very human factors that one has to consider and solve, right? Because I think it's not just the technical standards, it's about how do you convince people to use the right tools that may be available? How do you make the diagnosis? What we see is that this is a disease where some of the symptoms are severe, so there is care seeking, but the gap is in that timely and accurate diagnosis is what the team also highlighted. I would like to go to Dr. Mukul Agarwal, taking now the doctor's perspective, and if you could share what a typical patient treatment looks like. We know that there are now medicines available to manage the condition. Also, how standard is this treatment? Is there a lot of heterogeneity? How often should the patient actually see the doctor? Is it a one-time consultation, or do you need frequent consultations, and why? Could you talk a little bit wearing your clinician's hat?
So, thank you, Dhananjay. So, sickle cell, like Mr. Gautam has already highlighted, that it's a multifaceted disease, and patients, they can present as early as infancy to well into their adulthood, depending on the complications and the combination of disease which they have. So, it's sickle, as we understand, it's not a single disease. It's a multitude of disease. So, patient can be having just a simple sickle trait, or the uh, compound heterozygous kind of a state in which sickle gene is combined with thalassemia and other things, or totally a homogeneous state in which both the alleles are of sickle. The last one is the most severe form, as we understand, as sickle cell disease. So it can present with anemia, that is less low hemoglobin and transfusion requirements because of hemolysis. And it can present with various kinds of crisis. The crisis most concerning and something which brings the patient to doctor is invariably a painful crisis. That is something which requires urgent attention, pain relief, and that is something which has been shown to be most effectively treated by the available treatments. Other crises like chest crisis or acute chest syndrome, which you understand, they require hospitalization most of the time. Then there are other problems or complications which can occur. They can have hepatic crisis, they can have bone crisis, they can have splenic sequestration crisis, so on and so forth. And it's been said that I think Dr. Deepti will elaborate further that sickle per se can affect almost any organ in the body. And it is a very common thing to rule out sickle in specialized centers when the patient present with these kind of symptoms. So the symptoms can vary from pain, jaundice, transfusion requirements, massive splenomegaly, bony pain, so on and so forth, and bone complication including avascular necrosis. All those things can occur. CNS complication including infarcts and early cognitive defects. All these things can occur with a sickle patient. When we say about this is the symptomatic heterogeneity with which the patient can present. All said and done, Indian sickle cell patients are slightly in a beneficial effect because of slightly higher concentration of hemoglobin F, which is more prevalent in the Indian population with sickle, and this kind of the symptoms as compared to the Western world counterparts. But all said and done, this is still not a benign disease at all and can affect many other organs as well. When we say to other kind of heterogeneity, so the patient who come to us, they are coming from various socioeconomic status and from different states, and we have seen patients who come in their toddler age, well into their adulthood, already diagnosed, not even diagnosed into their adulthood, and all kind of heterogeneity is seen in this regard. Then when you ask me about how much, how many times should the patient visit the doctor? This for the diagnostic part, the diagnosis is simple and it remains with the patient for the lifetime. So whether the patient is diagnosed as a sickle cell disease, sickle cell trait, or a compound heterozygous kind of a state, that diagnosis is there with the patient for the lifetime. So diagnostically, the visit is, 1 or 2 visits. First, when the patient gives samples. Second, when the patient when the patient is having suspicion, you give the sample for the test, that is hemoglobin electrophoresis or HPLC. And secondly, when he comes to collect and it's being counseled about it. See, so that is for the diagnostic part. Regarding the treatment, so treatment of the sickle has evolved over time. We understand now that the definitive treatment for or the curative treatment is stem cell transplant, which is kind of widely available in India, but at least in the private sector. Not many of the government sector hospitals are doing it. All other treatments are supportive in nature and for symptomatic management. The cornerstone of treatment is hydroxyurea, a drug which has been approved for over 20, 30 years now, and still not available across India, or not very, adequately treatment across India. This is a good drug, but in untrained or unprofessional hand, this can be a dangerous drug as well. So there are certain side effects which needs to be monitored, especially when the patients are on a titrating kind of a dose initially. The drug has a hold up kind of a dose, and initially we call the patient every 1 to 3 months to put them on a maximum tolerated dose of hydroxyurea. Together with this, the patients are put on folic acid for combating the hemolysis. They are given vaccination shots if not received earlier at the first or second visit. And children who are less than 5 years or less than 10 years, they are given prophylactic medications, antibiotics for prevention of infection. So that is broadly how you want the patient to visit. So in our clinic, when the patients are coming, we call them after the initial, 2-3 visits for the treatment aspect. After 2-3 visits, we call them on a 3-monthly visit. Unfortunately, most of these patients, when they are traveling from far off places, they are not able to make on time or are skipping their visits, which leads to inadequate kind of a follow-up. I hope that summarizes my part.
Yes, thank you. Thank you very much, Dr. Mukul. I think that clarifies both, the patient side as well as what the typical clinician experience is. Let's bring in Dr. Srivastav. Dr. Srivastav, from a programmatic lens, if I could ask you to highlight kind of the major successes that the government has had over the last few years, as well as the main challenges that you face in running this program across many states and at the national level.
So thank you, Dhananjay. The concern was that when we started this intervention of sickle cell disease in India, that was in 2012-13, when NHM started as an intervention. And intervention was that we were coming to know that there is an issue which was not foreseen by the government earlier. And when Honorable Prime Minister became he was CM in Gujarat, and he started this program in 2008-9 in Gujarat itself. The first program which was started in sickle cell disease was in Gujarat itself. Gujarat had much of the, if you see the Dang area, Valsad area, they have a length, breadth. There's a long belt of sickle cell disease patient. So the program was started there. When he became the prime minister, and we started this intervention at NHM, we got the support from the central government saying, yes, this is very important and we should initiate. We wrote to the states that we want to know the exact data for the SCD, which was a difficult task for us, because through ICMR there were certain projects which were done, but it was if we talk about our country, it is quite minuscule. So those projects were done, but the data was insufficient to go ahead. But somehow we had some data from e-Raktkosh, which was one of our key portal, which said that how much transfusion is being taken by the thalassemia or sickle cell disease. Second one more, which was important, was about the ICMR data as a Jan Vigyan project, which highlighted about the how many the sickle cell disease patients are there and what is the, and the third thing which came into picture was the organizations who were working for the SCD. They told us that these are so many patients which are not known to people. So we started at NHM. We started basically doing the screening, prevention, management, both ways. And there were centers which were created, like ICHS Center, Integrated Center for Hemoglobinopathies and Hemophilia, was established by NHM at district level. So there the management was done. The children started getting the hydroxyurea, the other management which was required, and the screening also started in the states, respective state. Now if you talk about Chhattisgarh, MP, they had a good data now on screening, because they started, I mean, they were very aggressive while doing it, because they know their picture of the state and the demography and the length to where the exactly these patients were residing, or their belts were there, where we could find the traits as well. I'm not talking about only the disease people, but also the trait people.
Right.
So this way we came up with, and finally, Honorable Prime Minister went to Japan saying, because he came to know about the CRISPR technology also. So he wanted that it should be initiated here, which was, I mean, which came here in India. It was initiated also by IGIB, but it took the wider picture. If you say, it started in 2021. Now, when Honorable Minister of Tribal Affairs, Honorable Arjun Mundaji, former Minister of Tribal Affairs, he was very keen on the subject. They started doing a small screening cohort through DBT, when where 1 crore people were screened, and they found that 7,000 people were found to be diseased into that. This became a challenge, and this much of the whether, because it was done in remote pockets of the country, and we find that tribal areas are much affected. That's why it gave impetus to the tribal. That was the reason it gave impetus to the, earlier it was like, it is in, I mean, you can find it in tribal as well as another population, because of the migration and the mutations both, because they're marrying in their close community also, but if a trade marries somewhere out of the community also, and the person is also a trade, they can have a chance. So it was in tribal as well as in other communities, but mostly it was found in tribals. But Dr. Deepthi will again re-emphasize on it, that it is not only in tribals but in other communities as well. So we started working on it, and in 2019, Ministry of Health took an initiative to take up the mission, sickle cell mission, along with the other ministries. Ministry of Tribal Affairs was one of the ministry, because tribals were much impacted. So it also came into limelight. Yes, tribals has to be given a privilege about this. We came up with the mission. Before that, we started working on the training modules for awareness, where Dr. Deepthi was made as a chairman of that committee, and we came up the awareness modules and the counseling modules and the management modules have also, where Dr. Tulika is said from AIMS, and other committee members and professors, they were and other people who came forward to prepare these management modules. That management modules, what exactly has to be done for the patients patients. So that was about the blood transfusion, about the other, I mean, how to go for the hydroxyurea, which what should be the how much time it should be taken, other things was screening, and the management pass was taken by the Ministry of Health, where Ministry of started doing the screening, and now it is, I mean, it's a commendable job, if you can say. Around 2 crore people have been screened across the country. This is a good telemedicine, because when we talk about the mission, it was only 7 crore people which were supposed to be screened in tribal areas and others. But now, if you see, 2 crore people in 1 year has already been screened, and all the commendable job has been done by Ministry of Health and Family Welfare. And they also said that the management, they started placing hydroxyurea in the PSC-CSCs also. So the SOPs were formed that how to be given, because we don't have the doctors as such in PSC, whether it's health and wellness centers and other places. So we started providing SOPs that how to provide hydroxyurea, and there was a portal also for sickle cell. There was a defined portal where people, when the person gets screened, it is uploaded in as a trait or a disease person. So we know how many disease, how many trait are there, and we can take care of them. That was one thing. And we came up in travel affairs. It was for awareness, where we started doing awareness in different languages, which was more important. The different languages were to be taken care. Similarly, at NHA, they started putting packages, that how to go about the packages, because if a patient has to go for public and private both, in the private also they should know what the facilities are being given by the government. So packages were defined. Now the packages are again revised, and they are going to be revised in I think within 3 months or so. So now patients has a flexibility to go in private as well as the public facility to avail the facilities. And similarly for the counseling and awareness, as I said, it is a job of every ministry, every person, I should say now, that one should know what exactly the hemoglobinopathies are, and they should be aware that they come forward for the voluntary screening. That is more important, because until unless people themselves knows about it and come for the voluntary screening, it will not be possible. So these were the broad areas where the government has emphasized on. And as I said, NHS is going to revise the packages because it's going to help the entire society for the patients, and this will be helpful in the public and private uh, places also, and the same packages will be adhere, I think, will be taken care by the NHM as well. So when government works, it means that everybody has to be in cognizance and they have to be together for coming up with the to fulfill the SCD mission. Thank you.
Thank you very much, Dr. Srivastav, to lay out the path that the government also took, right? The historical path and where it is now, which is really commendable. Is Dr. Jain here? Okay, great. Yeah, I see her with.
Can you see me now?
Yes,
Yes.
yes, Dr. Jain.
Yeah, I'm there.
Okay, wonderful. So, Dr. Jain, perhaps I mean, you wear multiple hats, but first on the topic that was being discussed, from an implementation perspective, a lot of work has been made on the guidelines, on the packages, etc. Are you able to hear me?
No, in bits. Like, no.
I see. Let me repeat. Is it better now?
Yes. Yes. Yes.
Okay. Okay. Sorry about I'm on a hotspot. So, Dr. Jain, I wanted to understand from you the major, I mean, we heard about the guidelines, much of the work that has been done already. Kind of what do you see as the major challenges from an implementation perspective? I'll ask you kind of questions related to the researcher hat that you also wear later. But from an implementation perspective, what are the big challenges that you see, particularly at the state levels, given that you're in Maharashtra, but you also visit many states?
Yes. I would say that first of all, we have been working for decades. For last 3 decades, many like me have been working on sickle cell disease in Gujarat, in Chhattisgarh, in different states. However, I must, I think, confess that we were not able to bring implementation of what we were doing throughout. We were working in our own areas, small. And I think the greatest role has been played by Vinita. I must appreciate that she brought sickle cell at a national level and got all of us together. We were working, but in patches. So the biggest challenge I see is the heterogeneity. Everything in sickle cell is heterogeneous. I cannot generalize anything like other diseases that this is going to be happening with this patient. It is heterogeneous, the geographical distribution, the phenotype, the severity of the disease, everything, the cultural aspect which Mr. Gautamji said. So everything is so heterogeneous and it is very difficult to cover everything at one thing. we cannot have one size for all patients. It is different for different patient. Even in my area, if I talk of Vidarbha, Nagpur, each patient would be different. I can't say all of them, I will give this, I will give that. Second is the level of care we are giving. The level of care is different in different regions. Of course, with the introduction of this mission project, it's going to be better, but it's challenging. The greatest challenge is this is a chronic disease, the compliance and the continuity of drug. The compliance and the continuity of drug. And you have to act at different levels. When you say elimination or you want to reduce, I think today in my country, the biggest challenge I have is that you have to act at antenatal, prenatal period. That is the only thing which I see will reduce birth of a child with disease. So we are making now programs where all antenatal mothers are screened, but still we need to have more facilities. Once they are screened, what next? How much do we have for prenatal diagnosis? And also the what we have implemented, the point of care test, I think that's a wonderful thing, but it needs more training of point, because each test has different interpretation and we are using different tests at different states and different levels. That needs, because otherwise we are going to have many wrong diagnoses. That needs more training.
Thank you very much, Dr. Jain. I'll just come back to you in a second. But before that, Murthy has been waiting patiently. Murthy, you help us take a step back because you work on tribal health in general, right? I think for many of the people in the room, this is kind of the bread and butter. But taking a step back and noticing that, or taking note of the fact that sickle cell disease is one of several problems that the tribal communities face. From that perspective, can you share any best practices that you might have learned from working in these with tribal communities? You had a lot of interesting things to say when we last spoke, but perhaps a quick summary, a 2-minute summary of what you've learned and how we can address this better.
Yeah, no, thank you, Dhananjay. As every panel member has very well articulated the complexity and criticality of this challenge, it has to be worked on multiple dimensions. Last time we spoke, I have shared with you a 3-pronged approach that we have. One, we work towards strengthening the health systems, work with the government, and 2, we work with the institutional building in terms of community institutions, and then we work on the knowledge and sharing the knowledge and preserving the knowledge, if you will. So it's a 3-pronged approach that can create the scale and possibly sustainable results. And thinking more so, to make it an inclusive and equitable process, we have begun to understand some of these challenges that the tribal community peoples face are very unique, and they carry an undue and disproportionate burden, whether it is health or any other societal challenges that they carry. So it's extremely important for us to make them a part of the solution and co-create the solutions that are sustained in their communities once we start seeing the progress. So those are the 3-pronged approach that we have seen, and the diversity, equity, and inclusion tools is what we begin to use, wherein we tend to use the representation of the tribal peoples on both on the supply side as well, as we begin to cater to their demands and creating an environment that is very inclusive of their knowledge, of their processes that can be brought to bear. So we are seeing success, but it is very initial days, and there's a long miles and a marathon to run. That's where we are. Yeah.
Thank you, Dr. Murthy. If I may just double click on one point, which was on the last mile delivery in these areas. Quite often they're also difficult to work in areas as well, right? So if you have any experiences from there on how to work there, how to kind of address those local conditions while providing services or strengthening the system.
Right. There is no easy or proven solution, as people have discussed even on this panel. They are in very remote locations, the tribal peoples, and we need to get there to gain access to them. And they don't speak our languages, and it's very difficult to comprehend or communicate or earn their trust. So it's a long journey, and one has to get there and bring them closer to the public health system that we have, working with some of the established health channels, if I may call them, that they have, like tribal healers, faith healers, and what have you. And we work with a bunch of institutional community institutions like self-help groups, NGOs, our established PRI, and a variety of channels, so that it is a multi-dimensional access to these problems.
Thank you very much, Dr. Murthy. I think those are very important points that we tend to ignore. Just the context is so different, and the ecosystem is different, and adapting and kind of using that to your benefit is critical.
Yeah.
Dr. Jain, I mean, just looking at time, maybe 2 to 3 minutes on the science side, right? You've been involved in some of the studies that have been ongoing in diagnostics, in therapies. If I were to ask you, what gives you, some of these developments, of course, some of them may not pan out, but what gives you hope on the innovation or science front for sickle cell disease?
Right. I think for the last 2 decades, the drug which we have, the best drug for sickle cell patient is hydroxyurea everywhere in the world. And all these days we were worried about the formulation, because pediatric formulation was not available and be given very young children. Now the liquid formulation is available, and even small tablets with 200 milligram hydroxyurea is available. So that problem is solved. However, I think there are few things which I am really not happy with the treatment with hydroxyurea. We cannot give hydroxyurea in pregnancy, and pregnancy is a period which I see now, since sickle patients are living longer, they are during pregnancy they suffer a lot. We cannot give hydroxyurea. So pregnancy is one thing. We have to look for something which we can give in pregnancy. Second is infertility. It has been seen that men taking have low sperm count. So that is what we have to see for another. Third, I think the biggest thing which will come up, which will be really a solution, is just single once a month something. If we have giving hydroxyurea for anybody, even if we take hydroxyurea every day for years together, nobody is going to take. The compliance is poor, and hence we have problems. So something which comes, which we can give, I think maybe parental, may not be oral. Oral will be best, but given once or once a month or once in 2 months. I hope something like that comes up. And the third thing is, we should look at now multi-organ damage. There should be, because hydroxyurea has not much improved the organ damage yet. And we need a drug which will prevent nephropathy, hepatopathy, other things, even splenic sequestration. So we're looking of such molecules, and I think they are in progress, such molecules. Anything specific? Because the time is limited.
Yes. I think that's a good overview. We have about 5 minutes left, which means a minute each for all of you. If you can do less, even better. That gives me time to summarize. Same question to everyone. What are since, I mean, a lot of our audience are funders, CSR. What are the top 2 things that funders and CSR organizations should support in the sickle cell disease area? This is not an area where a lot of funders are currently writing checks, but if we could, change that, what are the top 2 things they should be funding in this area? Maybe starting with Dr. Jain, since you just spoke.
Okay. I think since I think government of India is looking after most of the things, I would say still my patients are deprived of stem cell transplant. Out of 100 patients, at least 2 or 3 need transplant, and they are not able to. So they should adopt such children who require. All don't need, only few need, and who have a HLMH sibling. I have such patients. If somebody can fund that. And of course, the future would be gene therapy. I think these are the 2 things I would like funders to be working on.
Great. I see Murthy on the screen next.
Yeah. First, let me mention that in observing 19th June as the World Sickle Cell Day, we are organizing camps, about close to 500 camps across 3 states and running across 38 districts and 142 blocks. So, and this wouldn't have happened without donors. And the donors fundamentally need to come with a clear commitment to such grisly, complex problems that they would take time. So it's a long-term commitment that one needs to bring in, and a close partnership with the government, and understanding and working very tightly with the beneficiaries, if you will. And as I mentioned previously, it has to be a multi-pronged approach wherein the partnership is clearly with the NGOs, the PRI, the SHGs, the tribal healers, making the community come together to co-create the solution. So once that is done, we hope to have solutions to some of these grisly problems. Yeah.
Gautamji, would you like to go next?
Yes, sir. Yes, sir. Thank you so much, sir. I would like to say that because of the two main things already Dr. Divijan Madam has shared, which is very important, I would like to add two more things, that we need education and awareness programs to be funded by the CSR for professional health worker. So it is right now very much needed regarding to success of the mission. And second thing, that we are from the patient parent organization. If the CSR budget can empower us to educate the common people, we can also be help to the common people to educate them also. So we should want to empower ourselves. So if companies would think about the advocacy group to empower them, it would be also grateful for the future. Thank you so much.
Thank you, Gautamji. Dr. Mukul?
Right, a couple of things. So, much of it has already been told by the previous speakers. First is about education and awareness. This is something which is lacking in the most endemic areas of the country. If the people are aware of their diagnosis, of the complications, and the treatment options, their overall condition will improve. They will be seeking therapies for their problems, and the compliance will improve. Second thing which I want to highlight, and which was also put forward by a cascade, is that adherence to treatment is a major issue. So if somehow the sponsors can help out with the adherence to treatment, be it hydroxyurea, be it stem cell transplant, all these therapies require regular follow-up with your physician. So something related to adherence, that will be very helpful, in a form of app or supporting their travels, anything like that. Thank you.
Thank you, Dr. Mukul. Dr. Vinita, you have the last word on this topic, if you have new things to add.
No, nothing. My previous speakers has already said everything. I mean, for prevention and management board, government is trying to do the best. But if the private partners also join for the CSR activities, the mission will take a new era. Will give a new era to
Is
India,
there,
especially, and to the world as well.
understood. Is there any particular place where the government would appreciate support from CSR or private philanthropy?
Government basically, as such, I don't think so. But for the institution, the private part, for the organizations, the organization should definitely be supported.
So thank you very much to the panelists. This was a very interesting discussion. I will not attempt to summarize it, given we're out of time and the volume of content we just heard. We will summarize this and share with the attendees. We will share the presentation deck as well as the recording. This is an interesting and important topic. It is interesting because it is so many things at once, right? It's a genetic disease which sees very limited attention in a country like India, unlike the West. There isn't yet an affordable permanent cure. There is a lot of stigma, so it reminds me of the TB world. It affects low-income populations, again, many similarities, and the adherence which came up really as a point to lifelong medication or condition management. So it makes it a tough problem to solve, but given the kind of the wisdom of the room and the efforts of the state and the central government, I see hope. I see there's lots to do, and we take back a bag of ideas to both private philanthropy as well as CSR organizations. So thank you very much for joining, sharing your wisdom. Thank you for the attendees. We will not be able to take any questions at this point, but happy to continue this conversation going forward. Thank you, and wishing you World Sickle Cell Day in advance.
Thank you. Bye-bye.
Bye.
Thank you so much.
Bye.
Thank you.
Thank you.